The industrialization of medicine has led almost certainly to many doctors leaving medicine. We have a real crisis. People are leaving medicine at a very rapid rate in the UK.
If we are trying to constantly cut the budgets, or at least not enable the budgets to meet the jobs they have to do, you're going to get a lot of problems. Okay?
Unless very different decisions are made in medicine, nationally and globally, in the next few years, we're heading for disaster.
Finding health and well-being are the greatest desires for doctors and patients who are confronted with a chronic disease or life-threatening illness. To increase the chances to recover from serious diseases, some doctors and professors in England have started to use a broader palette of treatments beyond the conventional. They work with integrative health and medicine that combines ancient treatments such as acupuncture and yoga, as well as mindfulness and meditation with modern medicine. They do this because they are extremely worried for the well-being of patients and also for doctors, and because they have found that the way we have treated patients for the last many decades is not enough.
I think what we have at the moment across Western Europe is a crisis in medicine. We have bright young people coming into medicine who are vocationally driven. By and large, they're not coming into medicine to make huge stacks of money. They're coming into medicine because it's a service. They are motivated to make things better. The industrialization of medicine has led almost certainly to many doctors leaving medicine. We have a real crisis. People are leaving medicine at a very rapid rate in the UK and quite a rapid rate in Germany and Switzerland as well.
If we are trying to constantly cut the budgets, or at least not enable the budgets to meet the jobs they have to do, you're going to get a lot of problems. Okay? And unfortunately, the NHS is riddled with inhibitors. Okay? There's lots of research on this. Bureaucracies, not having enough time with the patients, right? Not feeling you've been properly trained. I mean, many things, right?
Unless very different decisions are made in medicine, nationally and globally, in the next few years, we're heading for disaster. Because issues like diabetes, obesity in the West, and all the diseases that are no longer responding to antibiotics globally, not to mention epidemics that can break out at any time. Currently, we are, I would think, desperately struggling at the bottom of a mountain. And there are totally different ways to handle this, which we're not yet using. To my way of thinking, we need an integration of many tried and trusted traditional practices of health, which could complement and enhance our largely drug-related approach at the moment.
To increase the chances for a healthy life for people suffering from chronic diseases, healthcare requires a new map to lead an exploration into a new paradigm for health. This involves a more compassionate kind of healthcare and innovative economic strategy. Integrative Health and Medicine is the name for this initiative, which is defined as the practice of medicine that reaffirms the importance of the relationship between practitioner and patient, focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic approaches, healthcare professionals, and disciplines to achieve optimal health and healing. One of the founding fathers of integrated medicine in England, Professor George Lewis, has conducted research in this area for over 35 years.
To stay fit enough to enjoy a wide
In the 1950s, doctors started to realize that exercise was good for their patients and for the general public health. According to George Lewis, doctors and people working within healthcare must realize that we need to surround patients with a broader approach to the understanding of healthcare and treatment of chronic diseases.
And that's what physical education is really all about.
If you look back to the 1950s, people didn't do lots of exercise. You wouldn't go into your GP and be recommended exercise. Now we know that exercise is good for dementia, diabetes, aches and pains. You can't walk into your doctor and not be told not to increase your exercise. Probably a little bit extreme in some instances, but we know it's a hugely powerful treatment. We are also beginning to realise that things like meditation and mindfulness, slowing down, managing how we manage our lives, is very powerful too. And we've got hard evidence. We've got evidence from genetics and evidence from diurnal cortisols that show us that these things make a difference. So recommending them, it's basically a no-brainer.
George Lewith, very early in his medical career, became interested in the fields outside of mainstream medicine, most significantly complementary therapies and education in the field of acupuncture.
I started learning about acupuncture in the late 70s and travelled to China, and I thought nobody told me about this at medical school. And I just became absolutely fascinated with all the things I hadn't been taught at medical school. I'd always wanted to do research, but I started out as a biochemist, a molecular biologist, and I drifted away from that into this area. So I became a clinician, and I became fascinated by all the things that everybody else rather dismissed. Now I think acupuncture is going to be the new way in. It's a bit like exercise for the conventional physicians, because we know how it works, we have good clinical trial evidence. It's almost malpractice not to use it if you're a physiotherapist or a conventional physician, and it's widely used across Europe.
Over the past 10 years, Professor Lewith has raised over £15 million for research focusing on chronic conditions such as pain and arthritis, as well as antimicrobial resistance and placebo. Herbal medicine research is of increasing importance.
Herbal medicine, I think, has really good phytopharmacology. We know that there are many mechanisms of actions from various herbs. We know they very often have 30 or 40 chemicals that act synergistically. That's why they can be quite powerful in antimicrobial work. They're anti-inflammatory, immune stimulatory, antibacterial, antiviral, all in one hit. So you need to think broadly about evidence, not just pharmaceutical preparations and not just placebo-controlled trials.
There is great potential benefiting patients in the clinical health research field of cancer survivorship.
Cancer survivorship is really important for us because as we get older, we're more likely to develop cancers, but it doesn't diminish the fear of cancer. So we need better ways of self-care, we need better ways of anxiety and depression reduction, and we need to think about how we can develop healthier lifestyles in terms of what we eat, how we exercise, whether we use meditation, acupuncture for symptom relief. There are all sorts of things we can do for cancer. We're looking at trials, for instance, at the moment for using acupuncture to diminish the side effects of chemotherapy and radiotherapy. We've got a big trial looking at various different kinds of meditation and mindfulness in ovarian cancer. We're working similarly with prostate cancer, and we've got a very large £2.5 million programme grant looking at the management of cancer in the community. People who may have had anxiety and depression around their cancer for years and not be surviving with a good quality of life. So there are all sorts of things we can use, both interventions, practitioner-based interventions, and also digital internet-based interventions that can help us manage this process. And it needs a bringing together of several different disciplines and the patients to select what they feel might help them.
In addition to clinical health research, Professor Lewith teaches doctors how to bring compassion and empathy into their clinical practice at the University of Westminster Centre of Resilience.
If you teach the doctors to perform in a slightly different way, you set a whole different agenda. So the whole process of teaching resilience and looking at why the system isn't working and why we're losing all these very bright, wonderful young people, and what we can do about it. And the NHS is very concerned because it can't operate primary care at the moment.
National Health System England's new chief executive, Simon Stephens, was quoted at a conference at the Centre of Resilience, stating that too many patients are being robbed of dignity and compassion because of a lack of local care. According to Professor Lewith, there is a new way of supporting doctors so they can better support their patients.
And what we're doing really with them is trying to make them stop, think, work out why they're there, focus on the patient and be really mindful of what they're doing, and not trying to stop the toxic system, but we're trying to help them manage the toxic system in a slightly better way. We've also demonstrated some of the more recent work we're doing, and we've produced a systematic review for JAMA, which is in press at the moment, We can demonstrate that small changes in complex toxic systems can make a huge difference to the doctors. So just small empowerment changes. Once that begins to happen, they manage their patients much better and they're much safer. They don't make mistakes because they're engaged rather than engaged with the computer or the box ticking, they're engaged with the patient. And it can be done in a way that is humanistic and doesn't necessarily take a lot of time. And mistakes are very expensive at a human and financial level.
Professor Paul Gilbert has received the prestigious Order of the British Empire for his life's work in mental health research. He focuses on compassionate mind training and compassionate focused therapy at the University of Derby. His work started back in the 1980s.
Throughout that time, I've studied mood disorders and in particular shame and self-criticism. And during the late 80s, early 90s, began to develop a therapy which we now call compassion-focused therapy, which is about helping patients to generate compassionate ideas, ways of behaving, ways of thinking, ways of feeling. And I'm delighted to say that now this type of therapy is spread around the world, and we're getting a lot of wonderful data to show that this can be a very helpful therapy to many people.
Compassion-focused therapy is the next generation of cognitive-based therapy. It is an evidence-based form of psychotherapy that draws upon our evolved capacity for compassion. It facilitates the alleviation of human suffering, not only for patients, but also for doctors.
Working with suffering every day, it has its impact on you. And if there's nowhere that you can actually share those feelings and talk about those feelings, your angers or your upsets or your fears, then it all has to go here, right?
With help from the King's Fund, compassionate-focused therapy can begin as early as teaching medical students in the beginning of their medical school training, which is a crucial time to develop a doctor's capacity for compassionate dialogue with their patients.
Now, some people who come into medical school are very, very bright, but they're not naturally, they don't naturally have a warmth about them, let's put it like that. So maybe there needs to be more thought given to people who are coming into medicine. That might be one thing, right? Same for all of the caring professions. We can't assume that everybody that passes the exams and passes an interview have the most caring temperaments. Maybe they do, but maybe they don't. So that's one issue. Once they've been through the door, we have to think, how does our training cultivate their natural empathic compassion, or even suppress it, right? Because there is some evidence that medical training actually suppresses what there is. So then we have the whole issues about fears, blocks and resistances that sometimes staff are actually somewhat frightened about compassion. We've had examples, we've done research on this, had examples where staff have been very concerned to touch a patient who's crying, for example, in case there's a complaint made against them, right? So there's a whole gamut of things about what it is that is a problem for compassion. So you have to think of compassion in terms of facilitators and inhibitors, right? So in fact that's true for any motivations. So you can identify the things that build it, that facilitate it, that create it, the conditions that create it, by creating supportive communities.
Professor Gilbert's team works out from a threefold approach to compassion. Compassion that can be received, compassion that can be given, and compassion for oneself.
The first flow of compassion is, and actually the first type of compassion that we train, is being open to the compassion that comes from other people. So compassion from other people, which can be people of the past, so activating memories of people that have been compassionate for us in the past. And or people that in this very moment of my life I feel as compassionate. The second flow of compassion is the compassion that we give to other people. So we really try to become a compassionate self that is sensitive to the suffering of other people and is able to and willing to help these people. And the third type of compassion is the compassion that we give to ourselves. So it's kind of self-compassion. And it's really, really important because other therapies might focus on just one of these components. And crucial for us is the fact that we focus on all three of them.
The big question is, of course, whether compassion-focused therapy has an impact on physical illness.
Yes, I think it's a really interesting question, compassion in relationship to physical illness, including cancer, right? So there are a couple of things that are very important. Firstly, can compassion training and compassion interventions have any impact on the prognosis and the disease trajectory? Can it have any impact on the experience of the process of dying from cancer, or recovering from cancer, hopefully? Actually, not everybody dies, obviously. And the answer is yes to both those things, right? So that is still being studied, and part of the reason is because we know that many of these processes, these pro-social processes, have an impact on immune systems. So this is very, very important.
Dr. Sila Ellworthy, 3 times nominated for the Nobel Peace Prize as founder of the Oxford Research Group, has worked worldwide with conflict resolution. According to Ellworthy, there is a lot to be learned from preventative action that can be directly utilized when working within healthcare systems.
There are so many sources that we could be drawing on to completely reshape our approach to health, not to mention prevention. Prevention in the area that I work with in conflict is absolutely vital. And at the moment, we spend a fraction. We spend, for every $1,185 we spend on fighting conflict, we spend $1 on preventing it, which is ludicrous because we now know enough about how prevention works. And in fact, I've taken examples from inoculation and immunization in health and applied them to conflict. Now I feel we know quite a lot about how to prevent conflict that could even be applied to health.
As Councillor on the World Future Council, she focuses on the key challenges facing global society today and building on communities that work.
I've basically drawn the information I used from what I read about the great successes of inoculation and immunization. Smallpox, for example, eradicated. And I know when I've applied the tried and trusted methods of preventing conflict, largely using local people. After I'd worked for 25 years at the nuclear level, working with nuclear weapons decision makers to lay the basis for treaties, I then turned my attention to what happens in hot conflict at local levels. And what I discovered, somewhat to my amazement, is that this was back in 2001 when we did the research, there were then 400 viable, measurable, locally led initiatives that were really working efficiently. Now there are 5 times that many. It's just grown like that, with the support of Peace Direct, which is another organisation I set up. And what we find is that these local people, they know more about resolving their problems than sending in armies from outside who know nothing about the local conditions and usually make a mess. So locally led is our mantra. And I believe that there are now people, certainly in many countries, in health practitioners who are undervalued. For example, like midwives. Midwives are being sidelined when their ancient skills are invaluable.
Dr. Ellworthy recently spoke at the Empathy and Compassion Society conference in Oslo, where doctors, researchers, and thought leaders gathered. Based on what she shared and heard, presence of mind is the key to restoring dignity and compassion between patient and doctor, healthcare leaders, and governments.
That the presence of mind of the practitioner is the vital ingredient. That it's not just the cognitive brilliance of a doctor, it's the heart brilliance as well. And if I may say so, the extension of the grandeur of that person's spirit.
The question is, what is the future of integrative health in medicine in England and abroad? And what is needed to develop compassionate caregivers, empowered leadership, and financial sustainability for a fully functioning integrative system of healthcare?
bringing compassion into the health service requires a lot more research, and my own personal opinion is that things have been thrown at the problem without really understanding what the problem is. And different areas, like compassion on an acute psychiatric unit, to bring compassion into an acute psychiatric unit might be quite different to bringing compassion into, say, a cancer unit. Maybe there will be overlaps, but there'll also be things that are different. For example, what it's stirred up in the client, or it's stirred up in the nurse or the doctor for somebody who is psychotic or very aggressive, would be quite different than what's stirred up in the doctor for somebody who's dying, reminding them that they too one day will die, right?
There isn't a perfect system. And it's increasingly financially driven, largely, I think, because of big pharma rather than doctors' salaries. And we need to begin to think about how we take that back, how we take ownership. It's not up to the healthcare professions. It's actually going to be the ordinary people who want to take ownership back of this. It's increasingly going to be that. It can't just be doctors telling them what to do. And it certainly can't be government telling them what to do, because they don't. Most Europeans and Americans don't trust government.
So we need a vision of how things could be in 10 years, 20 years, if we applied what we're talking about. So if the initiatives you're describing to me could paint a picture of how this could affect the entire world, to have this integrative system of medicine, how the military could build it in, how the doctors' organizations, how the pharmaceuticals could be engaged as well. Because, you know, they've done some bad things, but they need to be brought in. And what an incredible change this could make to everybody's life. Massive. Much bigger than any cancer drug, forget it. That is going to be the change of the future.